All right, so this is really meant to be interactive, and Ashley has shared with you my contact information, my phone number, my work email. Feel free to reach out even in between sessions or even after at the end of all of this. If you want to ever discuss a case, feel free to hold on to my contact information. I'm happy to try to be a resource of sorts to all of you as you guys are trying to expand your capacity around hepatitis B. So this 5-part series is going to try to kind of start with the basics with a little bit of epidemiology. Today we're going to be really focused on identifying regions where Hep B is prevalent and discuss the importance of screening patients from these regions, describe some barriers around screening in patient populations. And as part of this, this is really meant to be case-based discussion. We're going to be asking in the subsequent weeks for people to volunteer cases around the various upcoming topics. And if we could, have everybody at one point during this 5-part series bring forth some case around hepatitis B, I think it would be a really excellent way for us to learn from one another. So with that in mind, I will remind you guys of that at the end to think about if you'd like to volunteer for the next week. All right, so let's get started. And for this week's case, we have actually a couple of videos towards the end, so we'll use that as kind of our point of case-based discussion. So it's estimated 2 billion people worldwide have been infected with hepatitis B, and we estimate that close to 260 million persons are chronically infected with Hep B. In the United States, we estimate around 850,000 people are living with hepatitis B infection, although that actual number may be as high as 2.2 million persons. And we're going to discuss a little bit about how foreign-born populations really shoulder the majority of this disease, and therefore we think our estimates could be underestimates of the true burden of infection. Hepatitis B is a leading cause of cirrhosis and liver cancer worldwide, and 30 to 50% of liver cancer, that's HCC, hepatocellular carcinoma, cases are associated with hepatitis B even in the absence of cirrhosis. So it's really different than other causes of liver disease and how they're tied to the risk of liver cancer. Other causes of liver disease typically necessitate the presence of cirrhosis or advanced fibrosis, a lot of scarring, to be the risk factor for liver cancer, but that's not the case with hepatitis B. Hepatitis B itself, even in the absence of a lot of scarring, can really portend a lot of risk around liver cancer. Hepatitis B is second only to tobacco in causing the most cancer-related deaths because of this association. And in terms of infectiousness, hepatitis B is thought to be 50 to 100 times more infectious than other viruses such as HIV. So one of the key challenges that we have is identifying at-risk populations. And as I mentioned, close to 260 million persons are infected with hepatitis B worldwide. But this map gives you a sense of how there's a geographic distribution that puts people who originate from some countries in a higher risk population group when we're talking about hepatitis B infection. So the 257 million persons worldwide translates to about 3.5% of the global population. 68% of this burden of infection is thought to be in Africa and Western Pacific regions of the globe. 2.7 million persons infected with Hep B are co-infected with HIV, and most infected persons were born before our highly effective hepatitis B vaccine became more widely used and available. And in this country, that happened in 1991 when we started implementing universal Hep B vaccination strategies. So the geographic distribution of chronic Hep B infection is important because it impacts what we see and who we think is at risk in the United States. So globally, you'll often see, when you look at the literature, regions of the globe kind of really broken up into categories based on the prevalence of Hep B surface antigen, which is the Hep B serological marker for infection. So areas of the globe in green have the highest Hep B surface antigen or Hep B infection prevalence of greater than or equal to 8%. So again, I just mentioned around 2/3 of the global burden of infection is found in African and Western Pacific regions. And then in dark blue, you see what we label as intermediate, which has been defined by World Health Organization and others as a surface antigen or chronic infection prevalence of 2 to 7%. And then here in the United States, we're in light blue, which, as you'll see based on this key here, correlates with less than 2% of our population being infected. But this can be somewhat misleading in that we know that given the high number of persons who move here, immigrate from countries where the prevalence is much higher, this can really impact, while the national prevalence is 2%, we know that some subgroup or populations within the United States are at higher risk for hepatitis B based on the country which you were born or originate from. So, and most notably, as I mentioned, foreign-born populations here in the United States really shoulder 2/3 or more of the hepatitis B infection nationally. Migration accounts for 95% of new cases that are reported in the United States, and 90% of foreign-born persons with Hep B migrate from regions of the world where we estimate the Hep B surface antigen prevalence to be in that intermediate or high endemic kind of category. Now, the top countries of origin of foreign-born persons with Hep B infection in the United States include China, Vietnam, Philippines, Dominican Republic, and Mexico. And we know that the hepatitis B prevalence rate among foreign-born persons, when we look at it by region, is much higher in African and Asian countries, where it's over 7 to 10%, followed by prevalence in persons originating from Oceania at close to 5%, the Caribbean 4.5%, and then all foreign-born persons. So it's really important to kind of keep in mind what the trends in immigration have been and how this relates to the practice setting that you are working in. And here you see, at least from the United States perspective, and I know we do have a provider from outside of the United States, but it's important to understand kind of immigrant population growth in the areas that you're practicing, as this can largely influence or impact how much Hep B infection you may see and which communities might be at highest risk. So this has led the World Health Organization and others globally and nationally to come together to try to define goals for elimination of hepatitis B as a public health threat by the year 2030. So the World Health Organization has set by 2030 a goal to have a 90% reduction in new hepatitis B infections and a 65% reduction in Hep B related deaths. So 2030 is actually not that far off from where we are now in 2019. And what you see here highlighted as of 2015, where we haven't made a lot of headway, is actually in diagnosis, which we would argue is a critical first step, right, to getting people into care, to do all of this great work around reduction of new infections and reduction in death. And this is followed very closely by very low rates of treatment in 10% of or less of patients. On the contrary, we have done a lot of great things globally to improve blood safety globally, which was a leading cause for Hep B transmission, and unfortunately still is a common way people can get Hep B infection in some parts of the world. And then also by expanding vaccine coverage, to 84% as of 2015. And in order to meet our 2030 targets of 90% reduction in new infections and 65% reduction in Hep B-related deaths, we need to move the needle in these areas highlighted in dark blue in order to achieve those goals. So it's important to start by understanding, once we have the context of who's at highest risk for Hep B infection, what are the common modes of transmission? So globally, 50% or more cases of Hep B are transmitted from mother to child or what we call vertical at the time of birth. This is very common in Asian countries, African countries. In African countries, there's probably high rates of also early childhood transmission, and I'll talk a little bit about why that's important. So horizontal within the household during early childhood. Again, the virus can survive for at least 7 days outside the body, and transmission at this time point at birth, right? Infection at birth and infection in early childhood is often asymptomatic. Because of where you are with your immune system at that point, most people go on to develop chronic infection if it's acquired at this very young age. This is very different than what we see in non-endemic countries, in which unprotected sexual intercourse is actually the most common mode of transmission in over 50% of cases. And this is followed by injection drug use, which we approximate 20% of cases. And unfortunately, we have seen a rise in the number of Hep B infection, as we've seen a rise in the opioid epidemic and increased use in injection drugs. And so this continues to be an important mode of transmission for us to be aware of. And then finally, globally, we still have a lot of iatrogenic transmission of Hep B through unsafe medical and dental practices, through reuse of non-sterilized needles and syringes in resource-limited or poor areas, contaminated blood products, and then thought to also have contribution from traditional medicine practices in which blood-blood exchange can happen. Unfortunately, there are also a lot of myths about how hepatitis B is transmitted. And so it's really, really important to understand how it is not transmitted. And this is an important information to share with people that you're screening in your patient populations and in those who get diagnosed. This is not a virus that's transmitted through casual contact, such as hugging, shaking hands, kissing, sneezing, coughing. Breastfeeding is not a mode of transmission, and so it's not considered a contraindication unless there's severe mastitis or overt blood in the breast milk. So it's considered safe to breastfeed even if you are Hep B or a Hep B infected woman. It is also not transmitted through sharing utensils or drinking glasses, or airborne, or transmitted through food and water. And unfortunately, there are a lot of common myths. We do a lot of community-based work around education in particularly foreign-born communities, where these questions quite commonly come up and are misperceived to be modes of transmission when they're not. The Hep B life cycle is important to understand in the face of particularly new therapies that are now being developed. And one of the kind of notable features of hepatitis B virus, unlike other viruses like hepatitis C, is that it incorporates into the host DNA genome. And this has made it more problematic to try to cure patients of Hep B, although the newest wave of therapies that are under clinical development are looking at ways to cure Hep B by targeting different points of the Hep B life cycle. So there are a number of entry inhibitors that are being studied. There are a number of agents to try to block integration of covalently closed DNA into the host genome that are being looked at. There are a number of capsid inhibitors that are being looked at. So essentially, we've taken apart this Hep B life cycle and now are developing targeted therapeutics and studying them to see if any of these, either in combination or as monotherapy, may lead to a cure of hepatitis B infection. So this is really important work. I just mentioned that the age at which you acquire this infection is really important in terms of the outcome. And what I mean by that is that when you acquire this infection at birth through mother-to-child transmission or in early childhood, you don't have a developed immune system, and you're more likely, 90% or more, are more likely to go on to develop chronic infection. This is very different because compared to those who acquire this as an adult, for example, through unprotected sexual intercourse, in which 85% of people actually clear this infection through their own immune system, and only 15% go on to develop chronic infection. So the age at which you acquire this infection in large part determines your risk to develop chronic infection. And that's why when we talk about more than 50% of cases of Hep B are thought to be transmitted from mother to child or in early childhood, particularly in regions of the world where um, Hep B screening, treatment, and vaccination and immunoprophylaxis measures are limited, is really an important concept to understand, to know where we should be allocating, potentially more resources to trying to reduce the burden of infection. So the age at which you acquire this and the time period at which you've had this all can influence the different stages at which we believe you to be over time with respect to this infection. So you're going to start to hear, you may have already heard about some of these terminologies such as immune tolerance and inactive carrier. The thing I'm going to really highlight in the series to come, we're not talking about treatment today. We're going to spend 2 sessions coming up on Hep B serologies and some of this terminology, because this terminology has been very fraught and problematic because in a lot of ways, they're not very good descriptive terms to tell us what's really going on with hepatitis B in an individual person. We do believe this period in the first 10 to 20 years of infection to be an immune tolerance phase. And so we'll talk a little bit about what that means and why do we assign these type of terms. Inactive carrier has now been replaced by other more descriptive terms that I think are of more value and meaning. But these are things that are still vestiges left over from the old terminology that's been in place for a very long time. Less than 15 to 30% of liver cancer cases are associated with Hep B and occur in the absence of cirrhosis or advanced fibrosis. So it's really important to understand that Hep B is directly oncogenic. It's very different than other causes of liver disease, and they're linked to liver cancer because you don't have to have cirrhosis to develop liver cancer. And unfortunately, we see very young persons develop liver cancer who are infected with Hep B. So who should we be screening or testing for hepatitis B? And so these are our guidelines, and we'll talk about what's also endorsed by the U.S. Preventative Services Task Force. So certainly persons born in high and intermediate endemic areas, so where regions of the world where you have greater than or equal to 2% Hep B surface antigen prevalence. So any place in green or dark blue on that map that I showed you very early on. US-born children of immigrants from high endemic areas. So if you have parents who were born in a region of the world where that was green and they were not vaccinated as infants in the United States or elsewhere, those people should also be tested for Hep B. Other groups that you should also be screening include household and sexual contacts of Hep B carriers. So once you identify somebody with Hep B, it's important to let them know that other people in the household should also be tested. Sexual contacts should also be tested to know their status. And this is helpful because testing can also lead to opportunities of prevention through a highly effective hepatitis B vaccine. Any persons who's injected drugs, persons with multiple sexual partners or history of STIs, sexually transmitted infections, men who have sex with men are at higher risk for Hep B infection, inmates of correctional facilities, any individual with chronically elevated ALT, AST, that workup should include Hep B testing. Individuals infected with HIV or hepatitis C, it's important to know whether or not they're dual infected or co-infected with Hep B infection. Any patient undergoing dialysis because of potential for blood-blood exchange through the dialysis machines. Patients who are immunosuppressed because of the risk of reactivation, which we will discuss in the 5th module. All pregnant women should be screened for hepatitis B infection. This will also be covered in that last module. And then infant born to Hep B infected mothers should all be tested as well. And there are some strategies to try to reduce transmission through immunoprophylaxis that we will also discuss in that 5th module. So the U.S. Preventative Services Task Force recommends screening for Hep B infection in persons who are at highest risk. These include persons born in regions where the prevalence of Hep B infection is greater than or equal to 2%. So any place in blue or red. And then US-born persons not vaccinated as infants whose parents were born in regions that are denoted in red are also highest risk. So they should also be screened. Why do we care so much about hepatitis B? We just talked a little bit about liver cancer, but over time, hepatitis B is still a leading cause for cirrhosis and end-stage liver disease or decompensated liver disease or liver failure. And of course, we talked about the link to liver cancer. Hep B is felt to cause more than 50% of liver cancer cases worldwide, and it is a direct carcinogen, second only to smoking tobacco in terms of causing cancer deaths worldwide. So it's very important public health consequence for patients and populations. Now, in the natural kind of disease progression with hepatitis B starts with acute infection, which may or may not be accompanied by any symptoms. The vast majority of people who acquire this infection are asymptomatic, although some people do present with very dramatic kind of viral prodrome syndromes with or without jaundice, fatigue, fevers, muscle aches. But the majority of patients, even with acute infection, are asymptomatic. And depending on the age at which you acquire acute infection, that influences your risk to develop chronic infection. And in those who develop chronic infection, up to 10% will develop liver cancer independent of cirrhosis in their lifetime. 30 to 40% of those with chronic infection over time in their lifetime will go on to develop cirrhosis, which is a fancy medical term for a lot of scarring in the liver. And this can lead to risk of liver failure, decompensated liver disease, need for liver transplant, and or risk of death. And hepatitis B is the sixth leading cause of liver transplantation here in the United States. What we do know is that the Hep B DNA viral load, so it's a DNA PCR test that we can check, that viral load is very much associated with risk of cirrhosis. So this is data from the prospective observational study that included long-term follow-up in a very large Taiwanese population called the REVEAL study. There have been many kind of sub-studies that have come out of this observational longitudinal cohort study, where they looked at surface antigen positive patients and related this to Hep B DNA and followed them over time. And what we know is that the higher your DNA or your viral load level, the higher your risk of developing cirrhosis over time. We also know that that DNA level correlates with increased risk of liver cancer. So the higher your Hep B DNA level persistently over time, the higher your risk of liver cancer over time. And one of the key features here is that even until a very late stage of cirrhosis that's decompensated or a very large tumor, Hep B is often thought of as a silent killer. Chronic Hep B infection, I can't say this enough, is largely asymptomatic, even with liver cancer and well-compensated cirrhosis. So it's really on us to be working from a public health and provider standpoint to try to identify populations that are at risk and offer screening as a critical first step to finding out who's infected to know how we can effectively manage them. It's also important to understand that if you just checked hepatic tests, liver tests, those could be normal in somebody who's got hepatitis B infection. So you need to do the active screening. And we're going to spend the next two sessions really talking about how you do the initial screening for Hep B, followed by the following workup. And as many as 2 out of 3 chronically infected persons living with Hep B virus are unaware or not yet diagnosed of their infection. All right, so there are a lot of barriers that still persist in terms of Hep B infection. So I wanted to mention a little bit about patient-related barriers. On the patient side, there often is a lack of understanding about hepatitis B infection, what screening is meant to do, how hepatitis B can be transmitted. There are a lot of cultural beliefs and stigma and shame around hepatitis B infection. There's a lot of concerns around privacy and who this data is shared with and sharing what this data can be used to do. I often will do a lot of work in foreign-born communities here in New York City, and I quite often get the question of, can I get deported for my hepatitis B status? And so really understanding what the privacy issues are and concerns on the patient side are important for us to be able to address some of these cultural or health literacy barriers to screening. It's important to communicate what the value of screening is and how we have highly effective treatment, that this is largely an asymptomatic infection or disease. And so therefore, if we're not doing active screening, even in asymptomatic individuals, we're likely to miss a lot of it. Additional barriers include financial barriers. A lot of our foreign-born populations in particular are not documented, not eligible for insurance, or do not have insurance, and therefore the cost of the test remains an issue. And then language barriers and how we communicate our messaging around Hep B still has room for optimization. So some of the ways to address some of these patient barriers, certainly here in New York City and state, we're quite lucky. We have very active and engaged public health departments that have created a lot of resources for communities that are at risk. Here in New York City, 40% or more of persons are not born in this country. So we have a lot of people who are at risk for hepatitis B, which has led to a lot of funding through public health agencies and our community health centers to offer free or discounted Hep B screening and even vaccination support services in those who are identified as negative and at risk. And then it's really important to provide appropriate patient education materials and to get the word out about Hep B. We've done a lot of work in trying to develop culturally specific targeted messaging, but there's also a lot that's already available through our partners at the CDC and local city and state public health departments, and available in various languages as well. It's important when we're trying to engage patients around Hep B screening to provide a context, to explain to them why it's important, that it's silent, try to elicit a family history to identify potential risk factors, discuss the risk of co-infection, obtaining concomitant alcohol and sexual use history, and explaining what it means to have Hep B infection. So once you get the test result, if it's positive, we have an obligation to be able to counsel and educate our patients about what it means to have Hep B infection, what ways we can help them, how it can be transmitted, prevented, and that we do have a highly effective vaccine to help us with this, and highly effective treatments to help try to curb or prevent bad long-term outcomes. There are a lot of not just patient barriers, but provider barriers. We often have a lot of things that we have to keep track of in a very short period of time that we're scheduled to see our patients. And primary care docs are really on the front line for a lot of this screening. And it can be really tough to keep up with the many different kind of metrics that we're being graded on in terms of who we should be thinking of for various screening measures. Hep B serologies are confusing and difficult to interpret, which is why we're actually going to spend the next 2 sessions talking about this to try to really overcome this barrier for providers who are learning to expand their capacity. Hep B guidelines over time have been conflicting and are confusing, so we're going to spend a lot of time breaking some of this down. And then, there are probably certain ways to try to leverage our electronic health records better to try to identify people who are at risk, and some work is being done by certain groups that I think all of us could learn from. So making Hep B risk assessments a routine part of your care, leveraging EHR prompts, risk assessments as standard intake forms can be really helpful. Understanding the guidelines at who's at risk, identifying effective ways to engage Hep B screening, learning how to effectively screen for Hep B and interpret those test results, identify opportunities for prevention through Hep B vaccines, understanding when and how to refer patients that you identify as infected, and then identifying other additional supportive services for patients that could be helpful. And then, of course, there are system level barriers. So working with your physician group, practice, clinic, hospital to make Hep B risk assessment an appropriate screening routine part of care is helpful. And then one major point we'll talk about today is this concept of really needing to screen even those who have reported to you that they've been vaccinated. So what studies have shown reportedly is that many people are either inappropriately vaccinated for Hep B without being tested first, and it's actually that they been infected the whole time, and they get this vaccine and think that they are protected when they still remain infected. So some people may have been infected with hepatitis B before they received Hep B vaccine. So therefore, it's important that we always start with Hep B screening, regardless of your vaccination history in certain patient populations. So persons born in geographic regions where Hep B prevalence is greater than or equal to 2%, US born persons not vaccinated as infants whose parents were born in regions of the world that have high Hep B surface antigen prevalence rate of greater than or equal to 8%, and then persons who received Hep B vaccinations as adolescents or adults after the initiation of risk behaviors. So all of these categories of people should warrant testing first. Even if they come and tell you, I've been vaccinated, they need to show you the result that they've been screened first before vaccinated if they're in one of these risk groups. There was actually, I always remember this study that was published in California where they actually did the study in East Asian immigrants in California, where everybody was asked to fill out a self-reported survey. And as part of that survey, they were asked, have you ever been vaccinated for hepatitis B? 15% of people who tested positive, so everybody filled out the survey, everybody got screened for Hep B. 15% of the people that they identified as having Hep B infection also reported being vaccinated to hepatitis B. So it's likely that they were never screened first and then vaccinated appropriately. So people are sometimes reassured even though they in fact have infection. All right, so with that in mind, I think now we're going to turn to a case discussion. So this is good. The first session, we're going to kind of give you guys the cases through these videos, and this is going to be talking about engagement around Hep B screening in a practice setting. So Ashley, can you launch the video?
Absolutely, just one moment.
Sure.
Yu Wen Lee is a 28-year-old woman who presents for a family planning visit. Yu Wen was born in the United States to parents who immigrated to the U.S. from Taiwan 30 years ago. She has no significant medical history. Hello, Miss Lee. I understand you're interested in becoming pregnant.
Yes, my husband and I have been talking about it for a while, and we think it's time. My parents will be so excited.
Have you told them yet?
Not yet, no. I wanted to talk to you first. I wanted to know what to expect before we started telling people.
Okay, well, this is a good place to start. There are a few tests we can consider, and we'll talk about your lifestyle habits and your health history.
Okay.
I see in your records that you received most of the recommended vaccines, and you were born in the U.S.?
Yes, my parents are from Taiwan, but they came to the U.S. before I was born.
Any family history of illness?
I don't think so. My dad takes medication for cholesterol, but he and mom are fine. And I'm my only child. I did have an aunt who died a couple years ago in Taiwan. They said it was liver cancer, but I didn't know her very well.
Okay, let me ask, have you ever heard of hepatitis B?
I've heard of hepatitis.
Well, hepatitis B is a virus. It can cause liver disease and liver cancer if it's not treated. The reason I ask is that hepatitis B is common in certain regions of the world. Taiwan is one of those areas.
Do you think that's what my aunt had?
Well, it's possible, but I couldn't say for sure. But we should definitely screen you for hepatitis B since your parents were born in Taiwan. National guidelines recommend a one-time screening of people born in countries with a high amount of hepatitis B, and that extends to children born in the U.S. to parents from those countries.
Oh, really? How's it transmitted? Can it harm my baby?
It can be transmitted through body fluids like blood or semen. For example, it can be transmitted through sexual contacts or injection drug use. And it can also be transmitted from mother to child during pregnancy or birth.
No, my mom and dad met in high school. There's no way they got a sexually transmitted disease. And I married my first serious boyfriend. No one in my family has ever used drugs. This can't apply to us.
Okay, let's just go ahead with the rest of the exam for now. Okay.
All All right, so we saw one version of the video. Would love to have folks take themselves off mute and open this up to discussion to talk a little bit about what could have been done better in that discussion. What are some ways we could optimize that conversation? And if your microphone's not working, feel free, or if you feel more comfortable, go ahead and use the chat function. So what do folks think? What could have been done better? Anybody want to chime in? I know somebody's taken themselves off mute.
She could have just mentioned.
We're getting some interesting feedback from someone. Taryn, would you mind starting again?
Okay.
Oh, it's coming from you. Oh no.
Oh. There we go. Oh. I don't know.
Aaron, try moving your microphone farther away from your speaker or turning your speaker down.
Is that better?
Yep, sounds better.
Okay. She could have just also mentioned that a lot of people that are born in other countries, not just a sexually transmitted infection or through drug use either, that a lot of it can be transmitted routine household contact, and mention maybe how long the virus can live outside the body, of like 7 days. So just kind of normalizing it and taking some of the stigma from sex and drugs out of it. Or just saying, you know, this is something we screen all pregnant women for. So I just wanted to let you know I'll be screening you. Could be just kind of saying this is something we do for everybody. Might have been a different approach.
Said normalizing this discussion, talking a little bit more. She talked a little bit about the provider talked a little bit about the guidelines and testing people whose parents were born in other countries, but explaining, you know, a little bit more about modes of transmission, including, you know, mother to child, early childhood, that it can live for, as you said, you know, for many days outside of the body. So talking about those additional risk factors instead of just highlighting injection drug use and unprotected sexual intercourse, that, you know, to be quite honest, the most common mode in this population of people where your parents are born in a high endemic area is not necessarily, you know, that mode of transmission. Do others have any comments or questions?
We do have a question from Katie.
Yeah, I see this. Okay, can you clarify what household contact is most common for transmission? I don't think it's known what specific thing. People have tried to assess like sharing of razors and other things that might increase blood-blood exposure. So we just know that there is higher risk, and that risk is particularly highly important for younger age persons, children, because of not only just the risk of acquiring the infection, but then if they do, the risk of developing chronic infection. So it's no one specific thing, but there are more intimate things that happen in a household that can put you at higher risk. Hopefully that answered that question. Any other points that people wanted to raise with respect to that case? Minawati, did you have something you wanted to share?
Yes, perhaps it's better to let her know that the infection can be prevented, and it can reduce the stigma of having a family with liver cancer, because, you know, perhaps she doesn't want to get action, and that's the denial. The way that she talked to the doctor is just her denial, I think.
Yeah, so I completely agree. I think highlighting that being aware of your status, is a potential opportunity, for prevention and lifelong immunity through a highly effective vaccine. So I think they're just different ways that, unless we're thinking kind of from the start, how are we going to have this conversation with our patients? We could kind of go down a rabbit hole that doesn't serve us very well in terms of trying to give patients a full perspective of why screening is important. I think someone else also mentioned that screening should be, is done in all pregnant women, women wanting to family plan because of the risk of mother to child. Yeah, so there are a lot of different ways that by highlighting and normalizing this discussion and highlighting the effective strategies we have to, around prevention, these are really great ways to kind of model a conversation. That's great.
We have a second video that highlights that as well. Ponni, would you like me to show that?
Yeah, why don't we go ahead and launch the second video that's an optimized version of what you just saw.
Let's just go ahead with the rest of the exam for now.
Do you think that's what my aunt had?
All I would say is that your aunt's history raises my level of concern. I recommend testing you for hepatitis B because your parents are from Taiwan and also because you're considering becoming pregnant. The Centers for Disease Control and Prevention recommend a one-time screening of people born in countries with a high amount of hepatitis B, like Taiwan. And that extends to children born in the US to parents from those countries, like yourself. It's especially important for you because one of the main ways hepatitis B is transmitted is from mother to child during pregnancy or birth.
You mean I could have gotten it from my mom without knowing it, and I could pass it on to my baby?
That's correct. Outside the US, mother-to-child transmission is the main route of transmission for hepatitis B.
But none of us are sick. I mean, my aunt died. Shouldn't we be sick?
People who have hepatitis B can seem fine for many years before they start to show symptoms. It's often silent. We want to treat anyone who's infected before they get sick, and also to prevent them from giving it to someone else.
I get it. I guess that's okay.
If the test comes back positive, which is unlikely, we can talk about how you can discuss this with your parents.
Oh, sounds a little scary.
Well, getting tested is the right thing to do, and it's a treatable disease. For now, we want to ensure that you have a safe pregnancy and a healthy baby.
All right, thank you.
Okay, so that was an optimized version. Be happy to open it up for a couple of minutes of discussion about what could even be done further, or what did people like about the second one, where there's even more room for improvement.
Hi there, this is Susan. I was thinking it's usually helpful to provide something printed too. I'll give you something printed regarding what we talked about, because sometimes, we talk about so many things during the visit. It'd be helpful to have something to refer to later.
So yeah, knowing what resources we can kind of give the patient to reassure them, and to provide a little bit more support and education beyond the time that you have to spend with the patient. That's an excellent idea. So it'd be a nice thing to add here. Anybody else? Okay. I know we're all still getting to know one another, but that was really great, and I appreciate everybody participating in the discussion. For the weeks to come, I would say that we're actually going to now reach out to you guys and ask for you guys to think about cases you would like to submit. Kind of one of the tenets of our provider education is this concept of case-based learning. So we really do want real cases that you guys may have come across, even if it's from a public health standpoint, a practice standpoint, international kind of question. Like we'd be happy to discuss it. So I think Ashley and Chris will be sending out, not in addition to the evaluations, the form. There's actually a structured form that we ask you to submit the case on so that we can kind of go through in a systematic fashion and then discuss the cases. And Taryn just reminded everybody, the CDC has nice, easy to understand handouts for patients with hepatitis B, also available in multiple languages. So yes, that was included as a bullet that I probably glossed over a little too quickly. So maybe Ashley and Chris, we could send that link out with some of those resources in the different languages to the learners today.
Thank you.
With everybody.
Absolutely.
Okay.
All right. Yeah, and again, just to reiterate, if anyone would like to fill out our structured form for a case presentation for next week, please let us know. We'll be sending out that form pretty much every week to you. So just fill that out and let us know, and we'll just give the floor to you at the end of the session next week.